when I was in my last year of medical school in 2018, I decided to bring my mom to our hospital for seasonal flu vaccination in winter. My attending professor vaccinated her, and after 1.5 hours, I saw a huge edema in the auxiliary site of injection. That time, I was so nervous and spoke with some of the professors about this side effect or actually vaccine reaction. All of them said, based on the former experiences, H1N1 influenza, smallpox, measles, and HPV vaccines can cause infrequent auxiliary lymphadenopathy. Fast forward to December 2019 and the appearance of the COVID-19 pandemic. Numerous people have been infected and died worldwide till now. As I work with multiple research teams worldwide, we mainly concentrated on different presentations of COVID-19 infection and published several studies like GI imaging presentation, incidental FDG uptake presentation, and cytokine profile and lymphocyte subsets in COVID-19 patients till now. After implementing various methods to deal with the destructive effects of the virus, efforts to develop an effective vaccine as the final solution accelerated. Since December 2020, various vaccines with mRNA, vector, and protein subunit mechanisms marketed over time. Pfizer, BioNTech, and Moderna are among the first vaccines approved emergency use authorization or EUA from the United States Food and Drug Administration or FDA. Vaccination began immediately in the United States, and after I had followed the related side effects of COVID-19 vaccines in a literature, I found that numerous studies showed lymphadenopathy associated COVID-19 vaccination. We decided to write a comprehensive review study on all COVID-19 patients presented with lymphadenopathy after all FDA or WHO approved COVID-19 vaccines. In our project, we identified approximately 2,000 studies through the initial search in databases such as Scopus, PubMed, Embase, Web of Science, and Google Scholar. After removing duplicates and title and abstract screening, 19 studies were selected as the candidates for assessment according to our eligibility criteria. In our study, we reviewed 68 cases, including 60 females and 8 males, with the age range of 32 to 76 years old. The majority of cases, around 82%, had a previous or active history of malignancy, including breast cancer in 40 cases, and other diseases, as you see in the table, in 16 cases. 5 cases presented with left palpable, painful or painless axillary or supraclavicular lymphadenopathy. And in 7 cases, the accurate characteristics of cases were not reported. About the vaccination-associated lymphadenopathy, When we wrote this review study, lymphadenopathy was reported after the first and second dosage of 3 types of COVID-19 vaccines, including Pfizer-BioNTech in 30 cases or 45%, Moderna in 17 cases or 25%, and Oxford AstraZeneca vaccines in 1 case. In 18 cases, vaccine type was not reported or only reported as mRNA COVID-19 vaccine. As for the imaging findings after COVID-19 vaccination, among 68 cases, the most applied radiologic modality for evaluating the suspicious lymph nodes was the ultrasound, which revealed lymph nodes enlargement with diffuse or focal cortical thickening in 29 cases, and preserved nodal hilar fat reported in 1 case. 6 cases were screened only by mammography. Additionally, lymph nodes demonstrated a necrotic pattern evidenced by homogeneous hypoechogenicity and the absence of internal vascular flow in a single case. In 2 cases, abnormal lymph nodes were detected in the chest CT scan performed due to other reasons. Abnormal axillary adenopathy was detected in 12 cases who underwent MR imaging for other reasons, such as breast cancer screening or even follow-up. Except for the lymph nodes enlargement, the feature reported was nodal cortical thickening ranging from 3 to 7 millimeter in 5 cases, irregular nodal cortex in 1 case, and preserved hilar fat reported in 2 cases. Otherwise, discriminative characteristic of lymph nodes involved by the COVID-19 infection was detected in this modality. Another modality was FDG PET-CT that demonstrated abnormal lymph nodes in 18 cases, as increased FDG uptake with the mean SUV max of 6.8 plus 3.4 gram per milliliter. Also, an incidental note was taken of abnormal FDG uptake in axillary nodes in the performed cardiac PET MRI in 1 case. We found that the mean of maximum lymph nodes dimension reported in all modalities was 20.9 plus 5.8 millimeter, range 13 to 30. We also reviewed the location of lymphadenopathy. As you see in the table, we found that lymphadenopathy was presented in the axillary region in 65 cases, supraclavicular in 9 cases, infraclavicular in 1 case, and subcortical or neck regions in 4 cases. One of the interesting points of this study is that we observed the median days of lymphadenopathy presentation after the first and second dosage of COVID-19 vaccines were observed in 12, range 3 to 26 days, and 5, range 1 to 22 days, respectively. About the Pfizer-BioNTech vaccine, the median days of lymphadenopathy presentation after the first and second dosage were 10.5 and 5 days, respectively. About the Moderna vaccine, lymphadenopathy was observed with median days of 11 and 3 respectively. Several studies showed increased axillary nodal FDG uptakes following, for instance, H1N1 influenza vaccination in the FDG PET-CT imaging. Most of them recommended interpreting radiologic findings in the setting of the location and time since vaccination. H1N1 vaccine, H1N1 virus vaccination can induce increased FDG uptake at the needle site and in ipsilateral axillary lymph nodes if the PET-CT is conducted within 14 days after vaccination. Also, in vital situations, an interval of 30 to 50 days from vaccination to PET-CT scan is considered. Overall, we found that 97% of imaging findings of lymphadenopathy after COVID-19 vaccination were seen from the first day to 4 weeks after vaccination, although lymphadenopathy remained after 5 and 6 weeks after the first and second dosage of COVID-19 vaccination, with decreased lymph node size and residual cortical thickening in 2 cases. Centers for Disease Control and Prevention, or CDC, reported the average duration presentation of lymphadenopathy after COVID-19 vaccines range from 2 to 4 days after either dosage of Pfizer-BioNTech and Moderna vaccines. Our results revealed that this duration was more than the CDC average, and in the recent studies, we found that lymphadenopathy was observed with the median days of 12 and 5 days after the first and second dosage of these COVID-19 vaccines, respectively. On the one hand, we observed several recommendations that have been suggested to lower the burden of diagnosis mistakes. For instance, the vaccine should be injected in the arm contralateral to the primary or suspected malignancy site, especially in the breast cancer case, with both dosage administered in the same arm. Or some recent studies suggested routine imaging screening for all individuals who presented lymphadenopathy followed by COVID-19 vaccination before or at least 4 to 6 weeks after the second dosage of COVID-19 vaccination. And also, in the case of screening for breast cancer, the follow-up schedule is controversial from 4 to 12 weeks after the second dose of COVID-19 vaccine. On the other hand, for the accurate imaging interpretation by the radiologist and to avoid false positive results in such patients, the date and the site of the vaccination were recommended to be mentioned on patients' history records. I'm gonna leave you with some statistics in the recent publications of Radiological Society of North America, or RSNA. This study revealed that ipsilateral axillary lymph node uptake at FDG PET-CT persists in 29% of patients between 7 to 10 weeks after the second dose of mRNA-based COVID-19 vaccination. I'm Dr. Pedram Keshavarz, and thank you.